This video is to assist staff with intubating COVID patients at Cabrini ED. This video has been adapted from the Safe Airway Society's recently released guidelines. This video will cover the principles of intubating COVID patients, the key differences between intubating these patients and other patients, the layout of cubicle 36, the team that will be required, the PPE they will wear, and the individual steps for intubation. The key principles are to ensure staff safety and minimise their exposure to aerosolised particles. We want to intervene early on these patients with intubation. We need to ensure our processes are efficient and that our communication between staff members is clear, and we want to standardise our practice. The key differences in intubating these patients is that we intubate them early. We know that if these patients have a high oxygen requirement on arrival, they will need intubation at some time. Ideally, this should occur in the intensive care unit, but for patients in extremis, it will need to occur in the ED in bed 36, which is a negative pressure room. Staff need to be wearing specific PPE when they're intubating these patients, and we avoid apneic oxygenation, and we choose to intubate via video laryngoscopy by the most experienced intubator. It's important that we understand the layout of cubicle 36. It has three components: the outside of the room, the ante-room, and the inside of the room. This is the outside of room 36, and this is the ante-room. Inside the ante-room, you will find your PPE equipment and a cupboard that will contain the specific airway tray for COVID patients. On the outside of the room are the controls for the negative pressure settings. Nursing staff will operate these. Inside the ante-room on the left side is a clean side where you will don your PPE, and a dirty side on the right where you will doff your PPE. Inside the room, you will find the patient. On the right-hand side of the room is the airway trolley and the circulation trolley. A COVID intubating drug box will be available for you. This will be kept in the purple zone drug room and be brought to room 36 when intubation is required. There is a COVID intubation drug order protocol on MedChart. There are also a number of cognitive aids that will be placed on the wall to assist the intubating team during the intubation. The cognitive aids on the wall are mostly from the Safe Airway Society guideline that was recently released. I encourage you all to read this thoroughly. This cognitive aid is going to be used to lay out the airway equipment. The airway equipment will be available in a dedicated COVID tray that will be in the ante-room. A staff member will bring that tray in and lay out the equipment based on the cognitive aid to match with the sections on the airway tray as shown below. The equipment that we laid out will be the same for every intubation. We will have equipment for males and for females. We have an intubation checklist. This should be used initially outside the room to confirm the team, the patient, the drugs and equipment. Then it will be used inside the room for a final check prior to commencing intubation. The three members of the intubating team will be positioned as shown on the screen. The runners will be outside of the room and in the ante-room. Before we go through the steps of intubation, it is incredibly important that we're familiar with the appropriate personal protective equipment, or PPE, for when performing intubations in COVID patients. This is paramount to staff safety to minimise exposure to any aerosolised particles or droplet particles. The bedside team will wear a chemo gown, which is grey, an N95 mask, a hat, shield and/or goggles depending on operator preference, one set of long sterile gloves and a second set of gloves over the top of this. The runners will be wearing a blue gown, an N95 mask, a face shield and one set of gloves. Inside the ante-room is a dedicated COVID intubating PPE trolley with all of the equipment you will require. Please note this is slightly different to the trolleys that will be in the rest of the department. Firstly, we will go through donning PPE for the bedside team. So this is the airway operator, the airway assistant, and the team leader. You will enter the ante-room and go to the left-hand side of the room, the clean side, and you will perform hand hygiene for 30 seconds. After this is completed, you will apply your grey chemo gown. When applying this gown, it is important that you secure the back of the gown around your neck first with the Velcro attachments, ensuring that it is not too tight and also not too loose. Once this is completed, you will wrap the gown around your back and secure it at your left-hand side. The next step is to apply your N95 mask. It's important that this fits properly. Place a small bend in the upper metal part of the mask first, then pass the mask over your face, ensuring that one of the straps is at the base of your neck and the other is on the crown of your head. Gently mould the top of the mask to your face and do a test to ensure that you have a good seal by breathing in and breathing out, and you should expect to feel some movement of the mask. You can also check at the top of the mask with your fingers to make sure no air leaks when you breathe out. The next step is putting on your eye protection. The Safe Airway Society recommends a face shield rather than goggles, but we found staff might like to wear both. So first apply your goggles, or if you already wear eyeglasses, you can keep them on. The Safe Airway Society also recommends a theatre hat. We find that if you put goggles on, you should then place the theatre hat, and then after the theatre hat has been placed, we then recommend placing the face shield. By applying this equipment in this order, it ensures that the hat is covering the hair and the forehead, and then that the shield is covering over the hat to ensure no skin is exposed to the patient. Once your headgear has been applied, perform hand hygiene again. And once you've completed your 30 seconds of hand hygiene, you will place your first set of gloves. The bedside team are going to wear 2 sets of gloves. The first set of gloves ideally should be long surgical sterile gloves. It's important that they are long so that they go over the sleeves of your gown. Once the first set of gloves have been applied, you can then put a second pair of gloves over the top. These can be standard gloves rather than long, sterile surgical gloves. This second set of gloves will be removed after intubation. You have now appropriately donned your PPE as a bedside team member for the intubation. Next, we are going to go through the process of donning PPE for the runners. Again, remember the runners will be located outside of the room and in the anteroom. Upon entering the anteroom, perform hand hygiene on the clean side of the room for 30 seconds, and then put on a blue gown. The gown goes on in the same way as the grey chemo gowns that are worn by the intubating team. Again, secure the back of the gown at your neck using the Velcro straps. And then wrap the gown around you and secure it at the left-hand side using the ropes provided. After this, you will apply your N95 mask. Again, the process should be the same. Put a gentle bend in the top of the mask. Take the straps, put the mask over the front of your face, and ensure that the bottom strap goes to the base of your neck and the top strap goes over the crown of your head. Mold the top part of the mask to your face Ensure the mask is appropriately covering your face and over your chin, and then perform a sniff test to ensure good seal. Next, place a face shield. Face shield and goggles are not required for the runners. Additionally, the Safe Airway Society doesn't recommend a theatre hat for runners, but if you have long hair or want hair out of your way, you can choose to wear a theatre hat. After you've performed your final bit of hand hygiene, you'll apply your gloves. Runners only need a single set of gloves, as opposed to the members of the bedside team who will be performing the intubation. Again, make sure the gloves are over the sleeves, and you have now successfully donned your PPE as a runner. We will now go through the correct procedure for doffing your PPE. This is the point at which a healthcare worker is at highest risk of contaminating themselves. After exiting from the inside of room 36, come into the ante-room, go to the dirty side to doff your PPE. Remember that all of the front of you is contaminated. This is important to remember when you remove your PPE. Start by undoing the ties and grab the front of your gown, which is contaminated. As you pull your gown off, you will roll it into itself. This keeps the contaminated area on the inside and the uncontaminated area on the outside. As you do this, you will pull your gloves off, leaving them inside the gown. Once you've done this, drop the gown and the gloves as one component into the bin. At this point, it is very important to perform 30 seconds of hand hygiene in case during removal of the gown you accidentally contaminated yourself. Once you've completed this hand hygiene, you are then going to remove your headgear. Remembering the front of your headgear is contaminated, so you are going to remove it from the back. We find that it's best to remove the hat and the shield as one unit, peeling it forward and dropping it into the bin. The next step is to remove your N95 mask from behind, flick your fingers under the straps, pull them over your head and drop the mask in the bin. Finally, remove your goggles or glasses by grabbing them from behind and dropping them in the bin. You will now perform a final 30 seconds of hand hygiene in case you have contaminated yourself again. Upon completion of this set of hand hygiene, you have successfully completed the doffing procedure of your PPE, and you are now able to leave the ante-room and return to the rest of the department. We are now going to go through the steps of intubating the patient. So the patient will be inside room 36. The team will enter after having applied their PPE. The first member of the team to enter will be the airway operator. They will be followed by the airway assistant. And then finally, they will be joined by the team leader, and they will stand in the positions that we talked about earlier in the video. The airway trolley, which has been set up with all the appropriate equipment, will be brought over to the airway assistant. At this point, the airway assistant will ensure that the bag valve mask circuit is appropriately assembled. It is important the airway circuit is appropriately assembled to minimize exposure to staff. You have the mask, the viral filter, the end-tidal CO2, and then the bag valve mask in that order. The airway assistant will connect the circuit to wall oxygen. They will not turn the oxygen on yet to minimize aerosolization risk in the room. The airway operator will connect the end-tidal CO2 tubing. And the airway operator in this scenario, because the patient is on a Hudson mask, will now turn off the oxygen in preparation for pre-oxygenation. Before we move on to pre-oxygenation, it is important to note that these patients might be significantly hypoxic. In the period before the team enters the room to perform intubation, the patient's oxygen delivery should be maximised by placing the patient in 45-degree head-up position, and they should remain in this position for pre-oxygenation. A critically unwell COVID-19 patient may be receiving high-flow oxygen via nasal cannulae, a simple face mask, or a non-rebreather mask. These devices should not be used for pre-oxygenation when the team is in position due to the risk of virus aerosolization. If the patient is receiving high-flow nasal oxygen, it should be turned off prior to removal of the patient's face mask and nasal cannulae to minimize aerosolization. Staff should maintain a minimum safe distance from the patient's airway until high-flow oxygen has been discontinued. Once oxygen has been turned off, mask or nasal cannulae will be removed by the airway operator, and they will then apply the circuit. They will apply the mask to the face with a two-handed vice grip to minimize leak. Once this has been applied, the airway assistant will turn on oxygen at the wall, and this begins 5 minutes of pre-oxygenation. The patient will be pre-oxygenated in this position, and there will be no ventilations during this time. After 5 minutes, the patient will be then laid down flat in preparation for intubation. Make a quick comment here about obtaining supplies that might not be in the room or have been forgotten. If you need anything, the team leader will communicate with the runner in the antechamber, who will then communicate with the runner outside of the room, who can get equipment from anywhere in the department. Equipment will be passed to the runner inside the ante room and then passed along to the team leader, who can then use the equipment in the room. At this stage, we are ready to give our induction medications. These will be administered by the team leader. After administration, pre-oxygenation will continue, but with no ventilations. Once muscle relaxation is achieved, the airway assistant will turn off oxygen on instruction by the airway operator. It is now safe to remove the circuit, as there is no oxygen running through it, and that minimises the risk of aerosolization. The airway operator will now begin to intubate the patient. A video laryngoscope is used, as this allows the operator to not be looking directly into the airway. The airway assistant will pass the appropriate airway equipment. We recommend a bougie with an appropriate size endotracheal tube over the top of it. Intubation will occur in the usual fashion. And once this is completed, the airway assistant will remove the bougie and they will inflate the ETT cuff. Now they will connect the circuit, and only now will they turn on the oxygen flow. And at this point, as the cuff is up and the circuit is sealed, it is safe to ventilate the patient. They will confirm intubation with a positive end-tidal CO2 trace. Now that intubation has been successful and the tube appropriately placed, the tube should now be secured in the usual fashion using tube ties. One comment about tube depth. Care should be taken to place the tube to the correct depth the first time to minimise the need for subsequent cuff deflations. Now that the patient is successfully intubated, we need to attach them to the ventilator. Again, this is a procedure that carries the risk of aerosolization if not done correctly. The recommendation is, prior to removing the mask from the tube, is that the tube is clamped. You can use chest tube clamps for this. Once the clamps are in place, you can disconnect the mask, connect the ventilator, ensure a good seal, unclamp the clamps, and turn on the ventilator. A word about the ventilator settings for these patients. You will need to adopt a lung protective approach when you choose your ventilator settings, and these settings should be chosen outside the room as part of your airway plan. For ongoing sedation of the patient, we recommend morphine and midazolam infusions and ongoing paralysis with an appropriate agent. This can be discussed with the intensive care unit. Now that intubation has been completed, the team can leave the room. It's important that they leave the room one at a time. This allows each team member to appropriately doff their PPE in the anteroom without contaminating each other. One staff member may need to remain to care for the patient until the nurse assigned to the patient can enter the room in the appropriate PPE to look after the patient. This staff member might already be in the room, in which case the airway team can leave one by one. In summary, intubating a COVID patient is a different procedure for all of us. It is important that we focus on staff safety and we minimise staff exposure to aerosolised virus particles. We do this by intubating in a negative pressure room, and we ensure that we are all wearing the appropriate PPE. For COVID patients, they need to be intubated early if there is an indication that they have a high oxygen requirement. Most of the time, COVID patients will be able to be intubated in the intensive care unit. Those patients, however, that are in extremis when they present to the ED will require intubation in room 36, our negative pressure ventilation room. And finally, it's important to remember that this video is an introduction to this new process to our staff. The process will likely change over time as we continue to train and simulate these intubation scenarios. So any feedback that you have, we encourage you to give it to the ED leadership team.